السلام عليكم، تسمعونا يا شباب؟
معنا الآن المحاضرة الثانية أونلاين من أمريكا الأستاذ الدكتور عبدالرحيم قاسم بعنوان Molecular Biomarker Testing in Precision Oncology and Evidence-Based Framework for Clinical Implementation. فليتفضل.
السلام عليكم ورحمة الله وبركاته. شكرا جزيلا للجنة المنظمة للدعوة الكريمة للمؤتمر هذا. قبل ما نبدأ خلينا نطلب من الزملاء الكرام كل واحد يعمل سايلنت ميوت لأنه في دردشة كثير و يعني تغطي على الصوت وتلخبط سلسلة الأفكار. اليوم إن شاء الله my name is Abdulrahim Qasem. I'm one of the medical oncologists and hematologists in Advent Health Cancer Center in the United States. I'm an oncologist and hematologist by training, so I will be talking more about the applications of molecular testing in clinical practice. So using the genetic and molecular testing informations and apply it to patient care. So today, inshallah, we will cover certain objectives. First of all, we'll understand the rationale and guideline recommendations for molecular testing in solid tumors. We'll identify key actionable biomarkers and their matched targeted therapies. We'll also try to describe the technologies used for DNA, RNA, and epigenetic testing. We'll recognize the major Can you guys mute? لو سمحتوا يا شباب mute. Recognize the major commercial NGS platforms and interpret their reports. And also we'll try to discuss the role of circulating tumor DNA, which we call the minimal residual disease or MRD signatera, in monitoring and adjusting therapy. So the first question is why molecular testing really matters. If we go back to the history from 1998 until 2024, there was at least 217 novel oncology drugs were FDA approved, and at least 83.4% were targeted therapies. And more than 50% of those were precision oncology therapies requiring pre-treatment molecular profiling. There was at least 3 tumor agnostic FDA approvals. What we mean tumor agnostic, meaning the treatment indication is based on the molecular testing regardless of the cancer of origin, regardless of what the primary tumor is, as long as the tumor has those molecular alterations or molecular testing, then those tumors can be treated with those medications. That's what we call tumor agnostic. So at least there was at least 3 FDA approved tumor agnostic MSI high or mismatch repair tumors, or tumors with TMB, tumor mutation burden more than 10 mutations per molecule, and NTRK fusions in which there is at least 3 approved targeted therapy for that. Now, comprehensive genomic profiling identified actionable alterations in up to a third of patients with advanced solid tumors. At least 30% of patients will have some actionable mutations. And the wider the platform used for testing, the more mutation can be picked up and more options for treatment. So if we look at the national guidelines for cancer care, including whether the NCCN guidelines, the ASCO guidelines, or the ESMO guidelines. ESMO is the European Society of Medical Oncology, ASCO, the American Society of Clinical Oncology, and NCCN is the National Cancer Network, Comprehensive Cancer Network guidelines. All of them, they list NGS or next generation sequencing or at least multi-gene panel testing as an important part of the oncology care. If we look at, this is kind of a busy slide, but the purpose of this slide mainly is to look at the available common molecular testing and alterations in different tumors and the approved therapies for that. So if you look at lung cancer, EGFR mutation, ALK fusion, ROS fusion, BRAF mutations, all of those are very essential in any newly diagnosed lung cancer right now. And in certain types of malignancies, there's different alterations as well. But it's a very long list of molecular testing, and what I listed here is only the most important ones and the ones that has a disease-altering indication. So presence of those molecular alterations actually change the landscape of treatment and give the patient much more chances of surviving and treating their underlying cancer. And so if you look at lung cancer, this slide is from what we call the NCCN guidelines or National Cancer Comprehensive Cancer Network. So for all cases of lung cancer, it is strongly recommended that you test for certain mutations, at least 8 mutations in the non-small cell lung cancer, in addition to the BDL1 testing and multi-gene panel testing. And squamous cell carcinoma, the incidence of those mutations is much less, but still highly recommended to do those if you have the ability to test for those. So I'll just present a case just to show you the importance of those molecular testing. So this is a patient that I saw in clinic approximately 2 years ago. Came in with, he's 64 years old, non-smoker, came in with cough, dyspnea. This is a copy of his PET scan at the time of diagnosis. You can see all of those dark spots. All of those dark spots are actually tumors or active tumor. You can see as a left lung mass, multiple bilateral lung nodules, diffuse skeletal metastasis. So it's stage 4 non-small cell lung cancer. We did the molecular testing for him, and this was kind of the test for this. This is how we get reported. On the right side here is the tissue-based next generation sequencing or NGS. You can see this platform looks, identify many tests for many molecular alterations or mutations or fusions. But in this patient, he did have the EGFR exon 19 mutation, and it was picked up also in the liquid biopsy or the plasma-based NGS or circulating, tumor DNA testing. You can see in those platforms also it tests for tumor mutation burden, it tests for MSI. So it gives you a lot of information that help you to make treatment decisions right away with the patient. So he does have this EGFR mutation, which makes the cancer susceptible to an oral targeted treatment called osimertinib or any of the other EGFR inhibitors. But you can see here he was started on this oral medication called osimertinib. And this is a targeted treatment, more so it's different than chemotherapy. But you can see 3 months later, his PET scan almost cleared up. So it's not just a fancy of testing and just more of an academic, talk. It's actually changing the care of patients and changing the survival. So this patient, this medicine and the test changed their life and outcome. And he is now 2 years out on the medication and still has a very good control of his disease. And, he lives as normal as possible. So if we're going to talk about technologies of this molecular testing, So I would like to summarize it in three important parts. The first part is the DNA-based testing. So when we run NGS or next generation sequencing, we need to capture the DNA-based testing, DNA-related mutations, and then RNA-based testing to capture any RNA fusions, and then epigenetic testing to capture any epigenetic alterations or hypermethylations. And just for the sake of time, those are kind of the different techniques that have been used. Dr. Rahiba in the previous talk, she mentioned the technologies and the testing of those. But what we use most widely right now is mainly the targeted gene panels, the NGS, and that can become a standard of care. RNA testing is very important, and there is many different techniques that we use, and as long as we test for those RNA fusions or RNA genes, so we don't miss any alterations that can help in finding a new treatment for the patient. Same thing for so just a very important point about the RNA sequencing. It's very important that we include an RNA-based panels in the next generation sequencing, because some fusions will be picked up only by RNA-based testing and not being picked by the routine or DNA-based NGS. Example of those are NRG1 fusions, which usually seen more often in patients with pancreatic cancer. And it's recommended now that as a part of the wide molecular testing, we include an RNA-based testing to avoid missing some of those fusions. If you combine DNA testing and RNA profiling, it can identify actionable alterations in up to 43.4% of patients, compared to only roughly 29.6 or 30% if you use the DNA techniques alone. And also there's many other technologies to pick up the epigenetic, and here is a list of the technologies that can be used. Mainly with the epigenetics, you try to identify any alterations in the protein production or hypermethylation that will alter the disease sensitivity or makes any prognostic implications. A very important part is this targeted methylation sequencing is the multi-cancer early detection test, or the MCED, which been considered as a kind of a screening test for cancer right now. You may have some reservations about using it broadly, but it's one of the promising technologies that still need validation. Clinical application of this epigenetic testing, it's prognostic in many cancers, including the glioblastoma. It predicts response to some certain treatment, including temozolomide. And also many tests approved for cancer screening, mainly colorectal cancer screening, either the EBI-ProColon or Cologuard testing. And as we mentioned, the methylation profiling also very important in reclassification and classification of CNS tumors, including gliomas. And the MCED, or multi-cancer early detection, there's like a Galleri test. It uses circulating tumor DNA methylation patterns to detect more than 50 cancer types and predict tissue of origin. There's many companies that actually do those testing. Those companies are based mainly in the US. I'm not aware of, I'm not sure what kind of companies they have availability in the Middle East, and I assume some of the labs may come up with their, panels. But the nationally recognized one are Foundation Medicine or Guardant Health, and Timbus AI or Caris Life Science. Most of those, initially when they started, some of them were very well known for their tissue-based NGS, and some came out with liquid-based NGS. But most of them now they do all of those. They kind of give you a very comprehensive profiling for the tumor, and give you a very detailed report that include the tissue-based NGS, the plasma-based NGS, which is called liquid biopsy, and they include also DNA-based testing, RNA-based testing, epigenetics, and they also give you information about available or approved medications, and availability of clinical trials for those patients. Some of those also, they run some of the testing that need to be done by immunohistochemical testing and protein level biomarkers, including BDL1, Claudin 18, which has been used widely in esophageal cancer now, HER2 testing, and mismatch repair testing as well. So this is a very quick, comparison between those major companies. But usually, if you use a tissue-based NGS, it usually takes anything between 2 to 3 weeks to get the results back. With the liquid biopsy, you can get the results back as soon as 7 days. And the last topic here I'm gonna cover is the Signatera MRD, which is a test that we use now to help identify minimal residual disease. And this test has been prognostic and guiding the treatment, trying to help the clinicians to make decisions whose patients need chemotherapy and who does not, and which patients may need intensification of treatment, and which patient may be eligible for the de-escalation of the treatment. It's still a growing field, and there is a lot of work and trials going in this field, trying to come up with more consensus and person-specific and disease-specific guidelines. But how it works, how this tumor works. So in general, just a very simple way, they do NGS in the tissue, and they identify certain tumor mutations, and then they develop what we call the custom panel design. At least 16 patient-specific clonal somatic variants are selected to create that personalized PCR-based assay. And then they do the plasma one, which is a blood draw. They draw blood, and they do the plasma-based circulating tumor DNA detection. So they look for multiplex PCR and NGS in the plasma for circulating tumor DNA that has a very similar somatic variant mutation to the tissue. So it's kind of a specific for that patients. And then the detection rate or the sensitivity of that tumor or the limit of detection varies depending on the company and the sensitivity of the test. But by providing this technique, you can actually try to identify some circulating tumor DNA that is shedding from the primary tumor, circulating in the blood, and by doing that, it may help you to identify patients who are at very high risk of recurrence, and also to monitor the response to treatment. So this kind of work has been done extensively in the colorectal cancer, and most of the data and studies has been published mainly in the colon cancer work. But there is many, it's expanding rapidly to the other types of tumors. But this Galaxy study, which was done in Japan, is called Circulate Japan Studies. They use this circulating tumor DNA in patients who had colon surgery. Patients with colon cancer, they undergo colon surgery to remove the tumor, stage 2 or stage 3. And then 4 weeks after the surgery, they check this circulating tumor DNA. They do send the primary tumor for a tissue-based NGS and to get that, BCR panel assay. And then if, they kind of see if the circulating tumor DNA is positive, then the risk of recurrence is very high. and if it is negative, then the risk of recurrence is very low. And this circulating tumor DNA can be actually turned positive and seen in the plasma up to 10 months before the radiographic appearance of recurrence. So this is an example of how it's reported. Like this is a patient that I saw in the clinic. So 4 weeks after surgery, he was positive. His Signatera was positive. And then we gave him chemotherapy, treated with chemotherapy. So all of his Signatera turned out negative. He finished chemotherapy probably around here after 6 months of chemotherapy, been observed after almost 10 months. He had some, or after a year, he had a positive Signatera with the recurrence. All of his scans now still not showing any signs of radiographic recurrence, but we know he does have recurrence because he does have some shedding of the DNA in his serum. So it's been used for monitoring right now and help in identifying patients who are at very high risk of recurrence, and also to monitor the treatment response and when to start treatment or escalate or de-escalate treatment. So for the sake of time, those are just an examples of studies and trials. They've been using this Signatera MRD in making decisions about which patients need chemotherapy or not in patients with stage 2 colon cancer. And with this study, that circulating tumor DNA at 4 weeks after surgery was a very predictive marker. Some more data in stage 3, and but currently, even with all of this data, we still need to be really careful in just depending on one marker to make a treatment decisions. As of now, most of the national guidelines identify it as a beneficial prognostic marker, but they still want you to actually depend on the clinical picture and use many prognostic factors to make treatment decisions. And now, excuse me. Now it's been used in many other cancers to either help identify risk of recurrence or monitoring the treatment or making decisions about when to stop the treatment. And it's mainly done by the Natera company, this Signatera testing, but also there is some other rising companies that look at that. And nowadays it's highly encouraged and recommended by many national guidelines to use both tissue-based and blood-based assays for newly diagnosed advanced cancers, because sometimes you can pick up mutations in the blood-based assay not seen in the tissue assay, and vice versa. And that's basically due to tumor heterogeneity. Within the tumor, you might find different clones with different mutations in the same tumor itself. So it is when you do the biopsy in the tissue, you may just sample one part of the tumor. However, the active shedding of the DNA and the circulating tumor DNA may capture many other mutations. So doing both blood-based assay and tissue-based assay will increase the chances of picking up any actionable mutation.
Dr. عبدالرحيم.
Yes.
الوقت لو سمح الله. Yes. شكرا يا دكتور، شكرا على المحاضرة القيمة هذه والتي استمتعنا فيها، وأنا أعرف أنه الكثير من الأسئلة، بس بنحاول أن احنا نخلي الأسئلة لآخر السيشن. شكرا دكتور، شكرا دكتور.
شكرا لكم.